This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
Welcome to the human side of healthcare. Delighted you're with us today. You know, hospitals do a lot to prevent you from coming to the hospital. We believe in prevention, and many people work to prevent you coming to trauma units or the emergency room. We're going to talk to two people from two different hospitals today about prevention of trauma and problems associated with trauma.
Cathy Glenn is our first guest. She is the Prevention Trauma Outreach Coordinator at Texas Health Presbyterian Hospital here in Dallas. Hi, Cathy. Thanks for joining us. Welcome to the show.
Thank you for having me today, Thomas.
So could you tell us from your perspective, with the holidays coming, what we might have our eye on to prevent trauma injuries?
Yes, I would love to do that. One of the things that we see a lot of during the holiday season are the consequences of people drinking too much alcohol. The holidays are a time of celebration, and people want to party and eat and drink and have a good time. But also the holidays, for many people, are a depressing time, particularly if they've lost family members or, have poor relationships with family. And the temptation to drink too much can ruin a holiday. What I would tell people that one of the ways they can keep themselves safe during the holiday and make family gatherings fun is to moderate the amount of alcohol that people drink. I don't know if our listenership is aware of what binge drinking is. I'm happy to define that. Binge drinking is a pattern of drinking that brings blood alcohol concentration to 0.08% or higher. And I think people would be pretty surprised at how little alcohol it takes to get to that. For men, it's about 5 or more drinks in 2 hours. For women, it's 4 or more drinks in a 2-hour period. And when you have adolescents, young adults and adolescents with smaller bodies, 3 drinks or more in 2 hours can bring blood alcohol up to the legal limit for teenage girls, and 3 to 5 drinks in a 2-hour period for teenage boys. And being intoxicated, particularly if they get behind the wheel and drive, can be a tragedy for everyone. And I also think our listenership is not really aware that 0.08% is the legal limit for alcohol intoxication, but that's not a magic number. People can be, their driving skills can be impaired even at levels below that, like 0.04%. Your attention and your reaction time slows.
So let me ask you this, in terms of drinking also in trauma units, do you see things like where people are assaulted or people have had too much to drink and unfortunately they have encounters and fights with other people?
Yes. Actually, what alcohol does is it weakens the brain mechanism that normally restrains our impulsive behaviors, such as aggression. And this can lead to people misjudging situations and overreacting. So it makes people very irritable. And if you add in that they have a weapon of some kind in their hand, a tragedy could happen. Someone could go to the hospital or be killed, and then another person's going to jail for a long time. Yes, alcohol is a big contributor towards fighting and violence.
You know, Thomas, National Injury Prevention Day is November the 18th. What a timely discussion of this topic.
I'm really impressed that not only is there an awareness of this, but literally we're talking about the hospitals in the DFW area have staff and departments that are completely focused on keeping us safe. I think this is so cool. So we are now going to talk to Courtney Edwards. She is the director of the Trauma Community Outreach at Parkland Health and Hospital System. Courtney, welcome to the program.
Thank you for having me.
You know, for our listeners out there, to help set the stage, when you think in terms of some level 1 trauma centers, and I know we have Parkland, we have JPS, we have Baylor Scott and White, of course, Children's Health, and we have level 2 trauma centers. For injury, what would you say is the leading cause for trauma admission?
It's not the most exciting, or what people would think after watching TV anytime soon with all the popular medical network shows out there. But it's actually falls. Falls is the number one reason why people are brought to the hospital center after a trauma injury.
Are the falls generally associated with older people, or do they hit all age categories?
We do see a lot of older adult falls, and that is a rising population that we're starting to see more and more of. But we see falls from all ages. We see a lot of construction-related falls, work-related falls that we can see in some of the younger population. And in very young kids, they're climbing up on swing sets and they're playing on monkey bars and they fall as well. And so that's one of the things about fall-related injuries is it hits all of us.
Do you have any feel, even in the Metroplex or nationally, of how many people are impacted by these types of injuries?
So here at Parkland, falls is, like I said, our leading reason why people come to the hospital. And that's 32% of our volume for admissions here at the trauma center are related to falls. Motor vehicle crashes are next at 19%. So there is a substantial difference in how frequently older adults fall and falls in general. One of the things that is kind of scary to me as a nurse taking care of people is that 1 in 4 of our older adults are going to fall this year, and less than half of them are going to talk to their doctors or their healthcare team about that fall event.
When you look at trauma and you look at trauma admissions, it's very similar to any disease where prevention is really the best solution. What would you describe and how would you say to our listeners they can prevent injuries?
So that's kind of one of our secrets within the trauma community across the state of Texas is that all of your trauma centers have people that work and focus specifically on preventing these events from happening. And we actually don't want you coming to the hospital after your fall events. And so many of us work on helping support the service providers in our areas that provide older adult fall prevention courses. We work together with our schools and our faith-based communities to provide education and resources to help people make smarter decisions, sometimes better decisions for them. We work with hospitals. We work with some nursing home facilities, assisted care facilities. We work with our policy advocates to really try to help support people so that they don't suffer from injuries and that their family members don't suffer from these injuries. Because that's, like you said, prevention is the best treatment. It's not what we have here in our hospitals that will really keep you safe throughout your lifetime.
This is Courtney Edwards from Parkland Health and Hospital System, and before her, Cathy Glenn from Texas Health Presbyterian Dallas, and the National Injury Prevention Day, November 18th, this Thursday. And the color is green. If you'd like to wear some green to commemorate, that would be great because we are all interested in preventing injuries. So much so, we're going to continue the conversation when we come back on the human side of healthcare.
This is the human side of healthcare, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
Welcome back. We're continuing this conversation, important conversation, with Courtney Edwards. She's the Trauma Community Outreach Director at Parkland Health and Hospital System. And trauma also has a dark side. Steve?
When you look at injury prevention, not just for falls, I guess things like elder abuse, neglect, violence, those types of things unfortunately contribute. Is that correct?
Absolutely, that's correct. And during different times of the seasons, we may see an increase in elder abuse, elder neglect. Life is difficult sometimes, and sometimes that gets put onto other people in ways that they may not be able to control. And so we're looking out for their well-being as well. And our goal is just to keep everyone safe and possible. So most of the hospitals have instituted different screening measures through their clinics and through their emergency departments to help the staff keep their eyes open for situations in which we may have elder abuse or child abuse or violence in the home that someone could be seeking help for and resources for.
You know, when you think in terms of prevention, we certainly want to do what's best for the individual. That's obviously the top priority. But trauma care is expensive. Can you elaborate a little bit on if you prevent the injury, you help save the cost of treatment?
Yes. Unfortunately, our healthcare system is quite expensive, and we have been working over the years to really switch that from a sick care system to the healthcare system, focusing on that prevention, because we know that the amount of dollars that we're going to spend in the last years of people's lives is astronomical compared to the overall dollars that we spend on their lives throughout their lifetime. And so most of the hospital systems, the trauma centers absolutely have them in place. But the focus and the effort on what we can do to prevent this from happening, how can we get that safety in your home so that if you do happen to trip and fall, that you may not have a broken hip? Or how can I make your legs a little bit stronger so that you don't slip in the bathroom and hit your head, or help with balance so that we can also keep you safe while you're driving as much as possible, or hanging lights outside your house, doing work around your house. I mean, that's our focus, is keeping you outside of the hospital doors as much as possible, and in your homes and your communities, in with your primary care doctors.
You know, you mentioned that hospitals have people that are based, they're really helping prevent people coming to the trauma unit. They're helping prevent accidents. And we're blessed in the Metroplex to have hospital systems. But do all hospitals, especially as we go into the rural communities, have people that focus just on prevention of trauma-related injuries?
So all of your trauma centers in the state of Texas have someone working towards injury and violence prevention. Your level 1 trauma centers, so those bigger hospitals that you think of that can care for any type of injury 24 hours a day, 365 days a year, they have people. My job is really focused on solely injury and violence prevention. How can I support the efforts in our communities, the efforts with the nurses and the doctors to make sure and that we are doing the best in keeping people safe, and when we discharge them back into the community, that hopefully they don't have another type of event that led them to the hospital for their injury this time around. And we all really work in that. And some of us are nurses like me. Some of us are based out of social work backgrounds or psychology backgrounds or paramedic backgrounds. And that's kind of the unique role of the hospital-based injury and violence prevention professional, is we come from so many backgrounds, but we're all focused on the same thing. And that's making our communities where people live, work, and play as safe as possible.
You know, you mentioned something in your answer that I really want to make sure our listeners understand. Many may think of emergency rooms as emergency rooms, which we certainly appreciate. But there are different levels, 4 different levels of trauma centers. And I'm not going to ask you to get into all the different levels because each plays an important role. But can you elaborate a little bit for our listeners the importance of a community having, say, a level 1 and level 2 trauma center, and kind of explain to them why that's so important?
So level 1 and level 2 trauma centers are built on the foundation that any patient that shows up to our doors who has been injured, we have the expert knowledge in both our nursing staff and our support services, our respiratory therapists, our nutritionists, all the other people that take care of those individuals and their doctors. We all have advanced knowledge and skills, advanced equipment, so that way we can keep you in your communities, help you heal from those injuries, and return you back into your community so that you can continue celebrating life with your family, with your friends, and at your workplace. And that is our goal. The rural communities around the state of Texas who have level 3 and level 4 trauma centers, they are a critical part of our system as well. They can care for and stabilize those patients to the best of their capability, and then they transfer, if necessary, to the level 1 and level 2 centers. So we open our doors and make sure we do everything we can to have a bed for those patients when they need that transfer for that higher level of care and expertise.
You know, Courtney, we've talked a little bit about things we do locally related to trauma. You did a really good job of explaining what the trauma centers do in Texas. But there's a day coming up very soon, November the 18th. Can you explain to our listeners why that day, as far as you're concerned, from a trauma point of view, is so important?
So November 18th is National Injury Prevention Day. And we are just wanting to highlight the fact that these injuries are preventable. We don't call them accidents. They're not car accidents. They're not bicycle accidents. They are preventable crashes or collisions. There are things that we can do to try to make you as safe as possible in your cities and communities. And this day, if you're looking around and seeing green on November 18th, it's just to highlight that we are here to put the foot on the gas and go towards prevention, and to really highlight that, and the people that work so hard, often behind the scenes, to make your cities and communities safer.
You know, based on your experience and the outreach you do in the community, the holidays are soon upon us in November and December and even New Year's Day. As you're talking to our listeners, what would be some of the things you would remind them of related to preventing injuries you've seen from holiday activities?
I would recommend people to check on their loved ones while we're cleaning house and trying to tidy up for family members. We might be getting on ladders, getting into attics to pull out decorations, and we can trip and fall. When we're around a whole lot of families sometimes, there can be car crashes as we're driving from one family home to the next family home. So be careful when you're driving. Focus on the driving, not on your cell phone or any other distractions that might be happening in the car. If you feel more comfortable driving in daytime hours, then drive in daytime hours, and try to extend your trips and your vacations in those directions. And always have a plan for if you're going to be drinking alcohol with friends and families and celebrations. Alcohol is not the bad thing. It's when we drink alcohol and then also get into a car or make other decisions. And so we just need to have a plan and be smart about what we're doing, and look out for our friends and our family members as well, and help them make good decisions as well. And then enjoy that time that you have being thankful for what we do have and celebrating together.
Courtney, before we wrap up, do you have a final summary thought for us?
I think some of the important things to consider is that, when we're in elementary school, we learn how to stop, drop, and roll for fires. And when we're in elementary school, we learn about bicycle safety and riding with our helmets. And sometimes as we start to get older in life and grow up and start having to do adult things, we forget some of those safety messages. And I think the important thing is just to remind ourselves that we need to take care of ourselves sometimes as much as we take care of others. And there are definite things that we need to open our eyes to sometimes, and may need to make those extra steps in that area to make sure that we set good examples for our children who are watching us, and also our grandparents who are watching us as well, because I can't tell my grandmother not to climb up that step stool when I'm doing the exact same thing without someone there in the room with me. So those are probably some of the things that I think would be helpful, perhaps.
Thank you, Courtney Edwards from Parkland Health and Hospital System, and Cathy Glenn from Presbyterian Hospital, Dallas. Just one of those tips could save us a lot of pain and a lot of money. When we come back now, we're going to go inside your heart. Stay with us. You'll find out what that's all about next.
Welcome back to the human side of healthcare, where we explore how to take better care of your health so you can live a happier, healthier life. With DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back. You know, Thomas, we've had a few guests on this show that have personally told us about AFib and how they deal with it. In fact, we even had Mark Cuban on the show.
And he's very open that he has AFib. His is fairly well controlled just by lifestyle and management. But some people, myself included, have atrial fibrillation, and that kind of management that Mark does will not keep the heart beating in normal rhythm. What you're about to hear is truly one of the modern medical miracles, a procedure where doctors can go into your heart with teeny tiny wires, find the problem, and terminate it. Dr. Sumeet Chhabra is with Texas Health Presbyterian Hospital in Plano. He's an electrophysiologist there, and he is going to describe this process called a cardiac ablation. Dr. Chhabra, welcome back to the program. Would you tell us how you go inside the heart to fix rhythm problems?
Sure. In fact, I love the question. I'd love to demystify the procedure because, you know, as an electrophysiologist, we think of it as a routine, but certainly to the lay public, it's not routine. Cardiac ablation is minimally invasive electrical heart surgery. And I know that's a mouthful, but it's actually become quite routine in that not just in the United States, but the world over, most ablation procedures are now done on an outpatient basis such that the patient gets the procedure and they go home the same day. So if somebody has an arrhythmia, and there's about a dozen different arrhythmias that the heart can sustain, AFib and atrial flutter being 2 of a dozen, we have learned over the last 30, 40 years that we can go into the heart. Surgeons used to do this in a big way where they'd have to do open heart surgery 30, 40 years ago, and they knew that they could go to certain regions of the heart where the nerve fibers branch or the nerve fiber sits or starts and put scar lines in. And then about 25 years ago, we realized that we can do the same thing. We'll call it cardiac ablation, but we do it minimally invasively by placing little wires through the veins in the groin, snaking those wires up using an X-ray camera into the heart, finding the fixed locations where nerve fibers exist and abnormal nerves exist, and using a lot of technology. These days we use ultrasound, we use very fancy computer systems that help the doctor help me make a computer map of someone's heart in real time. So within 20 minutes after we're putting wires in from the legs, I have 6 wires in someone's heart. I'm doing an ultrasound of their heart, I'm doing an X-ray of their heart, and the computer and I are making a beautiful computer map of their heart, figuring out where the normal signals are and where the abnormal signals are. Once the abnormal signals are found, which takes about an hour just to get the wires in and find the signals that are abnormal, the second hour really is the doctor manipulating these little teeny tiny wires in the patient's heart. Patient is under anesthesia, but sometimes semi-awake, but very comfortable. And we find those spots that need to be cauterized, or sometimes we freeze, sometimes we cauterize. And people always ask me, well, gosh, doctor, don't I need those spots? Or, you know, why are you purposely damaging things in the heart? And the answer is, out of the gate, those spots were abnormal. I'll joke with the patient back that actually we're trying to make their heart back to normal as if it's the heart of a healthy 25-year-old kid and not maybe a 75-year-old man or woman that came to us with abnormal areas that are misfiring. So once we're done, and we've gotten rid of those areas that are abnormal, all the wires come out. We have a lot of little devices we put into the legs to seal up those little puncture sites. Patients have to do bed rest for a period of a couple hours. After maybe 4 hours, they get up, walk around the hospital. Most hospitals have a ward, cardiac ward, that's basically designed like a big circle, and they get to walk around. We make sure that they're healed up very well. The effects of anesthesia are coming out of their system. And if they look good, feel good, there's no kind of reaction to any of the stuff we used, they get to go home. And the first night or two, they just kind of heal up. And honestly, we let people drive cars in 3 days and go back to, gym activity, heavy lifting activity in 7 days. And it's amazing, but for most ablations now, we quote people's success rates in the 90 to 95 percentiles, meaning we expect this to be fixed. And for 5 or 10% of people, they may have to come back and we may have to do more to really get from point A to point B. But for most people, we expect this to be the procedure that is the definitive fix for their arrhythmia.
Once it's fixed, all problems solved, no side effects, no residuals, or are there some residuals from having it in the first place?
Yeah, there's any procedure obviously has risks. I mean, the main risk these days, believe it or not, that we quote really have to do with just the act of having a procedure in general. There's always the going under anesthesia. There's always the meds we give. There's always the chance of, allergic reactions to something. Sometimes we have to give IV contrast, IV dye, just like people get for CAT scans. But if somebody fell into the group, that 95% group, where everything went the way it should, we're very happy, and there's really no residual bad effects. The residual effects are good effects in that the patient is fixed. It's always disheartening if the patient comes back and they still have arrhythmias and they have to get more ablation. It's disheartening for the doctor. I'll tell you, listen, like all the listeners to know, it's disheartening for the doctor too, because we want our patients to be healthy. We want them, there's no better reward being a doctor than seeing the patient healthy, the family's happy, patient's happy. The doctor is very happy then. So if the patient needs more, the doctor feels like we have to get this patient fixed now. In terms of, there are some arrhythmias some people have, so this is a COVID discussion too. With COVID patients, I've noticed in most arrhythmia patients, usually there's one thing going on, just, in general, the general population. In COVID patients, a lot of times you get into the heart and there's 3 arrhythmias going on. So, those can be challenging, and sometimes you have to, get what you can get, and obviously make sure the patient is safe at all times. Sometimes with COVID, actually they have 2 at the time of the procedure, and then 6 months later a 3rd one pops up, so that's frustrating for everybody. But I think having a good relationship with your doctor, good open discussions, patients doing their own research and coming up to us with questions. I love when patients come with me with research and questions, because it becomes more of a partnership and we can get through this together. So I think ultimately, to demystify ablation, it's really become first-line therapy in the United States.
That is truly amazing. You mentioned that younger people were getting it related to COVID. Do you have any idea why younger people?
Yeah, that's a good question. And some of this may be a chicken and egg phenomenon. So if I have a 70-year-old man that comes in with AFib, it's chicken and egg. I don't know if maybe he was bound to have AFib anyway because, his driver's license says he's 70 years old now, or maybe he had a little bit of AFib, it just wasn't picked up, because that's very, very common, unfortunately, out there. And maybe this just, if you already had AFib pre-existing, COVID can definitely make it worse. But in a young patient who tells me that, Doc, I've been, exerciseaholic, and I've been going to the gym. I'm a gym rat, and I've never had palpitations, and now every time I go to the gym, I'm having palpitations. And oh, by the way, I had COVID 2 months ago. It's pretty much from the COVID. I don't think it just happened spontaneously. So, some of this, again, is I joke with patients, we have to be like detectives. We have to put on our detective hat and try to figure out, well, what came first. But, the preponderance of younger patients coming in with arrhythmias, and specifically AFib, that's different. That's a little bit different. We didn't have that 2 years ago.
Yeah, that's amazing. It's sad that that these younger people are having this affect their lives like that at that age.
Absolutely. But hopefully we're getting the message out today, and hopefully patients are, if they're on the fence about maybe I should go get this checked out, I would absolutely say get it checked out. It never hurts. In medicine, it never hurts to know and get more data. It's helpful.
So as an electrophysiologist, when people come in and say, well, Doc, I had my watch go off and I'm not sure about this, how valid are the watch technologies for you as a clinician?
Yeah, this is always the million-dollar question, I'd say, because now there's so many of them too, so many different brands, and there's the different algorithms, and even the same brand, there's a new model every year. It ends up being, there's only a couple of them that are really FDA approved that give very good fidelity signals in terms of the EKG that the watch or the little monitor on the phone reports. What I'd say, though, is we do use them. I mean, we find them helpful, and I've a lot of friends who are electrophysiologists around the country, and we talk at our conferences and our meetings about this. It is helpful. If somebody, has a pretty predictable heart rate pattern. The patient tells me, Doc, I walk or I bike or I fish, and this is what my heart rate is. And there's a break in his or her pattern, and the watch is showing the same thing the patient's feeling. Usually that's real. I mean, if the patient, before we had watches, we went with symptoms. And the patient says, Doc, I used to be able to go, fish all day and I was fine. And now midway through the day, it's hot outside, I'm dehydrated. I feel like I'm getting woozy out there. I feel like my pulse is a little fast. And the watch clearly shows that the pulse, picked up, and the patient felt it at the same time. It's real. I obviously, then this becomes the beginning of the medical evaluation, where I have to give them a, dedicated, FDA-approved for medical grade use cardiac monitor. We use these really sophisticated monitors these days that are live monitors. They're cell phone-based systems. I can monitor my patient, can go to the lake and go fishing on a long weekend, and I can call him while he's on the lake and say, listen, you're in something. You got to stop right now. It's happened. That's a true story that's happened. So, it begins the process of discovery. And if we can discover something and help somebody and prevent a stroke, prevent a heart attack, I think we've accomplished some good here.
Dr. Sumeet Chhabra, he's an electrophysiologist at Texas Health Presbyterian Hospital, Plano. Thank you for that great description of how you fix hearts. And by the way, that interview is on our podcast, The Human Side of Healthcare, if you'd like to check that out. Now, coming up next, where people go when they're finished at the hospital but still need more care. Next on The Human Side of Healthcare.
Covering the healthcare topics that matter most to North Texas. This is The Human Side of Healthcare with DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back. We talk about hospitals and you think about driving by our 90-member hospitals. Many times you go there to give birth to a baby. Maybe you have appendicitis and you need to have an operation. We take care of you for a short period of time while you're going through something we refer to as the need for acute care because of your illness. But there's another skilled team of healthcare heroes that work in other hospitals that are known as longer-term hospitals. We refer to them as LTACs. But you go there for an extended period of treatment. Maybe you were in a car accident. Maybe you had a stroke where you need care beyond what you received in one of our hospitals. Today, we want to salute those healthcare heroes and learn more about what they do. We are delighted that we've got Audra Early with us. She's Senior Vice President and does work in strategy and network development at Kindred Healthcare. Audra, welcome to the show.
Steve, thank you for having me. It's a pleasure to be here today.
So, Audra, as I mentioned when I opened the show, can you help our listeners better understand exactly what LTAC care is?
Certainly. I'll start with the fact that most people who need inpatient hospital services generally start at an acute care hospital, and they're there for a relatively short stay. However, if a patient should require an extended care stay, they may be discharged to another post-acute setting to complete their recovery. Long-term acute care hospitals, or LTACs, are really facilities that specialize in the treatment of patients with more serious medical conditions, those who are critically ill and require acute care for an extended period. Typically, patients in an LTAC were originally discharged from an intensive care unit, and that care that they require is more than can be provided in a lower level of care. More or less, LTACs deliver a continuation of hospital-level care in a longer-term setting.
So, Audra, what is post-acute continuation of care?
The post-acute continuum broadly refers to a range of different settings where care can be delivered, but they're generally determined based on the intensity of treatment that a patient may need in their recovery. The different post-acute settings I'm referring to include LTACs, which really provide the highest level of intensity, but there are also rehabilitation centers, skilled nursing facilities, and home health, which provide the lower level of intensity. A few things that differentiate LTACs from other post-acute settings is their ability to provide ICU level care. They have on-site services similar to those that you would find in an acute care hospital, such as dialysis, laboratory, radiology, therapy, and around-the-clock 24/7 nursing and respiratory care.
That's a great description of what long-term acute care is. What types of patients generally are we talking about?
Yeah, great question, Steve. The types of patients we generally treat are those that require prolonged mechanical ventilation for respiratory failure, those with complicated or severe infections such as sepsis, or who may be on multiple IV medications, and those that may require extensive post-surgical care, such as a patient who's had an organ transplant. Also, it's not uncommon for patients in an LTAC to have 3 or more active diagnoses at the same time, or they may be someone who has suffered an acute episode on top of a chronic illness. For example, a patient who requires mechanical ventilation due to respiratory failure, and they require complex wound care, and they require dialysis, or someone whose illness has been further complicated by an underlying chronic disease like heart failure or diabetes. These are the patients that will generally require that extended time to recover from their illness.
Would a patient, say, for example, that's unfortunately in a car accident, could someone like that be a candidate that would be transferred, say, to a long-term acute care setting?
Certainly. Oftentimes, those are very complex cases, and they may involve, due to the trauma, neurological issues as well as respiratory issues and other underlying medical conditions that must be treated. But at some point, they're also going to need a level of recovery. And oftentimes, LTACs can be the setting that start the rehabilitation process. The main determinant would be that their medical condition is the primary focus, while the patient still also needs rehabilitation therapy.
Now, when we're talking about patients that are in a long-term acute care hospital, what would you say the average length of stay is?
I appreciate that you asked this question because I think we do get asked this question a lot. And I think that there are some misperceptions about how long a patient is either required or should stay in an LTAC. And because of that, I will answer that in 2 different ways, Steve. First, from a care perspective, the amount of time a patient may stay in an LTAC will vary. And it largely depends upon their illness and their injury and the extent of the complications and their treatment goals. We recognize that not all patients will experience the same recovery time. And therefore, the length of stay, it's based upon a patient's individualized treatment plan, which is created by their physician and their care team. Their recovery time could average between 3 and 4 weeks, but for some patients, it could be shorter or longer. The other important component in answering this question is from a regulatory perspective. To qualify as a long-term acute care hospital for Medicare payment, an LTAC facility has to meet Medicare's conditions of participation and have an average length of stay greater than 25 days for its Medicare patient population. However, a length of stay requirement does not apply for other subsets of patients, such as those with private or commercial insurance or Medicare Advantage. The important takeaway is that not all patients are required to stay 25 days in an LTAC. Some may stay for a shorter period, while others may stay longer.
Do your patients generally come from a hospital, or can they walk straight in the door?
Yeah, the majority of patients that are admitted to an LTAC do come from an acute care hospital. As mentioned, many of them are discharged directly from an intensive care unit. However, patients can be admitted directly from other settings, and they are, such as from skilled nursing facilities, rehabilitation centers, doctor's offices, or even home, certainly depending upon their benefit provider. But as long as there is a physician order and the patient meets the appropriate requirements for admissions to an LTAC, they can be admitted from outside the hospital.
Audra, you've been doing this for a long time. For our listeners out there that are having to make decisions about post-acute care, what are some things that they really need to consider?
Yeah, there are 3 things I would really encourage people to think about when making decisions about their post-acute options, including LTAC. And the first is for any listener who is a family member of a loved one in a hospital, it is so important to get involved and engaged with your loved one's treatment plan and care team. Speak with your doctors, case managers, social workers about the best options for extended care if, your loved one should need it, but especially if they have been in intensive care for an extended period. Be sure to ask your physician whether an LTAC would be a more appropriate setting for recovery versus a skilled nursing facility. The second would be where patients choose to recover after they leave the hospital can make a significant difference in the quality and the speed of their recovery. When patients receive the appropriate and right level of care in the right setting and at the right time, it greatly decreases the potential of an adverse event, like having to be readmitted back to an acute care hospital or failing to complete their treatment plan or meeting their recovery goals. Any of these would be an undesirable outcome and could set a patient's recovery back. And lastly, not every patient will need an LTAC as part of their recovery. Truly, only about 1 to 2% of all discharges from an acute care hospital would benefit from the care we provide. Those that would benefit the most from an LTAC as part of their recovery are this most difficult to treat, critically ill patient that needs that extended recovery time in a setting that combines both intensive care with specialized rehabilitation, and their care requires a daily physician visit.
Thanks, Audra. That's Audra Early. She's a Senior Vice President at Kindred Healthcare. Steve?
Thanks for joining us today. Don't forget Thursday, November 18th, National Injury Prevention Day. Have a safe week. Join us next Sunday for the human side of healthcare.